Hello, bonjour, and welcome everyone to our first public webinar in a series offered as part of Healthcare Excellence Canada's new program, Sparking Change in the Appropriate Use of Antipsychotics. The program aims to support long-term care homes across Canada to improve the appropriate use of antipsychotics through person-centered care. I'm Nicole Pollock. I'm a senior program lead on the Health Innovation Programs team at Healthcare Excellence Canada. My pronouns are she, her, and I'll be your host for today's webinar. We are pleased to offer French simultaneous interpretation. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point during the webinar in English or French by typing them into the chat box, and then we'll address as many of the questions as possible during the Q&A session near the end of the webinar. If you need support at any time, please reach out to our tech support, also using the chat feature. This session is being recorded, and the recording will be made available in the coming days through our YouTube channel, which will be linked in the chat. And in addition, the award launch webinar recordings will be available through the program e-bulletins for those registered in the program, and more on that later. So I wanted to start by acknowledging that I'm joining you from my home in Ottawa, which is currently very beautiful, sunny, dare I say, spring-like. And this is on the traditional and unceded territory of the Algonquin Nation. So I recognize and appreciate my ability as a settler to live here with my family. Healthcare Excellence Canada is also located in Ottawa, but with staff all across the country. And HEC honors the traditional territories upon which our staff and partners live. I invite you to share who you are and where you're joining from in the chat box, if you haven't already. So a bit about Healthcare Excellence Canada, if you're not already familiar with us and what we do. HEC is a not-for-profit funded by Health Canada. We collaborate with diverse people and organizations across the country to spread innovations, build capability, and catalyze policy changes that improve healthcare safety and quality. So I'd like to acknowledge and thank our supporting organizations who are helping to promote this Sparking Change program and may also have volunteers be reviewers for the award submissions in the program. The objectives today of this webinar is to provide a brief overview of the AUA approach and dive a little deeper into some of its components. In particular, we want to offer guidance and tools support behavior tracking and huddles. And then, of course, to answer any questions you may have about that. So I'm excited to introduce and welcome our speaker for today. Cynthia Sinclair is a coach and advisor with HEC for this program. She's a retired registered nurse who has 35 plus years in her career, which has spanned across several sectors, though her passion is clearly in long-term care. She has served in a variety of roles with the Winnipeg Regional Health Authority, as well as becoming a director of care for a large Winnipeg long-term care home and CEO of a long-term care home in England. Cynthia is a graduate of HEC's Extra Executive Training Program, where her intervention project set the foundation for future AUA collaboratives across the country. So using her expertise and experience, Cynthia has worked tirelessly with many long-term care homes and organizations to create and sustain person-centered care environments that improve the lives of residents. So we're very grateful to be working closely with Cynthia on the design and delivery of this program. Once again, please feel free to drop any questions throughout the presentation into the chat box, and we'll try to address them at the end. So over to you, Cynthia.
Well, thank you. I'm really pleased to be here with you today. I want to start by acknowledging that I reside just outside of Winnipeg, which is located within Treaty 1 territory, the traditional lands of the Anishinaabe, the Anininawak, and the Dakota Oyate peoples, and is the birthplace of the Métis Nation and the heart of the Métis Nation homeland. Next slide. So you have all seen this infographic. I'm sure you're all familiar with it already. Today I will be focusing on taking a full team approach. Specifically, I'm going to speak about behavior mapping and using huddles effectively. Next slide, please. Before I get to huddles and behavior mapping, I want to reiterate that the AUA approach requires us to shift our thinking away from the traditional model of care delivery into a more person-centered approach. This will mean working together with management and care teams to help identify and support changes in how we deliver care and how we can work together to ensure not only the efficient running of the home, but more importantly, ensure that how we deliver services respects individual resident dignity, choice, and needs as much as possible. There are many models of care out there now that emphasize this kind of holistic approach to dementia care. They include things like PIECES, TIPA Snow, Dementiability, Butterfly House Model, Plane Tree, etc. All excuse me, all are good examples of how we can create an environment and work in a way that promotes more independence and choice in a home-like environment. These models of care tend to promote adjusting institutional routines. And if you look at the slide, the photographs that you see there are real examples of homes that have attempted to remove that institutional-like setting and create a more home-like environment. I want you to think back to if you were present on Julie's webinar in January. She gave a really interesting example of how stressful things can be and how we routinize things. Julie talked about the admission process. And let's delve into that a little bit again. When a family member gets a call that a bed is available for their loved one, they usually have anywhere from hours to a day or two at most to have their loved one admitted into the home. That alone creates a very stressful, fraught environment. Now, once the resident arrives, they are automatically assigned usually to the previous resident's old room. They are given that previous resident's spot in the dining room, and they are typically given that resident's bath day and time uh, for their own now. Um, and interestingly, this usually happens without any consideration of the new residents' regular routines and habits. So we often don't take the time because the admission process is so rushed to determine what might be best for that resident. For myself, if I were your resident in care, and because you were following the home's routines and you tried to get me up between 5 and 6 in the morning, because I don't get up that early, you might find that I have responsive behaviors as well. Next slide. So really, person-centered care is about embracing a culture change. And there are some distinct pillars of embracing person-centered care that you can see on the slide. Getting to know the resident is probably one of the most important things you can do. Getting to know the resident, who they were before the diagnosis of dementia. What did they do for work? What did they do for leisure? Who were their people? What were their relationships like? What were their daily routines like? All very important. What mattered to them? All very important. Also very important to understand who the resident is now. What are their strengths that are remaining? What are they no longer capable of? What is still important to them? Who are the people that they still connect with, and how do they connect? All that is critically important. We get that information through pre-admission meetings and questionnaires. We have sit-down discussions on the day of admission or during care plan reviews where we meet with the resident and the family. Sometimes we approach families ad hoc if we're trying to figure out an issue or we have questions. But one of our best resources is to simply watch the resident and get to know the resident, who they are in the moment. Another important pillar is working as a team. You've heard it said that it takes a village to raise a child. Well, it takes a village to properly support someone living with dementia. And so when I say a team, I don't just mean the nurses and personal support workers and healthcare aides. I mean everyone that touches the resident. And that can include people like the housekeeper on the floor, the dietary aide, the recreational therapist, the social worker, nurses, healthcare aides, etc. They're all important. They all have different experiences with the resident and different relationships and all have valuable insight, and you should capitalize on that. Getting creative with your ideas and care plans is also really important. You've heard the term think outside the box. I like to say think like there is no box because you really do need to get creative. And it might require some assistance from management to help remove barriers to some of your creative ideas. And a really quick example is where one home that I'm aware of turned the residents' washroom into an outhouse because this gentleman lived in the woods and wouldn't go anywhere except uh, up against a tree or in an outhouse. And so to curb his behaviors, they created an outhouse in his bathroom. They used wallpaper and made the room look like wood. They made the door look like an outhouse door. They got a wooden toilet seat and they covered the porcelain with a black plastic garbage bag. Lo and behold, it worked. But it took some help from management and department heads to break down some of the barriers that people perceived were preventing them from being that creative. Communicating the care plan effectively is another really important pillar of this because if people don't know what the plan is, it won't happen. As a director of care, as a manager, and as someone that has worked closely with Manitoba Health Standards folks, I have witnessed and seen some of the most beautiful care plans written. They're gorgeous. They're individualized, they're person-centered, they're detailed, they're lovely. And they live on paper or in the computer only. That's useless. People need to see and understand what they need to do when they work with that resident every single day. And so you need to make sure that your care plan is a living, dynamic document and that changes get communicated rapidly and to all team members. You need to remember too that you might need to be updating your care plan more often than quarterly because the resident changes not on a quarterly schedule, but just as their dementia progresses. And as their dementia progresses, their needs are going to change and your strategies will have to change. Next slide, please. I also want to spend a little bit of time talking about the concept of resistance to care. Um, I'm often dismayed and I'm a little saddened when I hear people say things like, Mrs. Smith is resistant to care. She's very combative. She hits us every time we approach. Oftentimes, it's very much our own approach that creates the problem and provokes an aggressive response. And we need to really stop and look at what the resident is doing. And we need to stop and consider what we're doing. I'll give you an example. Let's say I am a healthcare aide and I need to get 10 residents into the dining room for lunch and I'm rushed. I'm already running behind. And so I rush in to Jane's room and I'm like, come on, Jane, let's go. We got to get to the dining room. We haven't got time. Get your sweater on. Let's get your shoes on. Let's go. Now, Jane, with her dementia, maybe can't interpret what I'm saying. She doesn't understand what's going on, but what she has left is her ability to interpret body language. And so she sees this as, oh my gosh, something's wrong. And she might get very combative because she might get very scared or she might get very angry. So we need to remember that with dementia, people are losing their executive functions. They cannot interpret language the same way. They cannot understand what they see or hear in the same way that we do. So we have to be the ones that adjust our approach. And instead of insisting on doing something with a resident and getting them more upset, we should be willing and able to pull back and say, you know what, I'll come back later. I'll think about how I approached and see if I can make a better approach in 10, 15 minutes or so. I've had staff say to me, but Cynthia, I have to go in there. John has soiled himself. I have to clean him up. Well, do you really right now? If he's really angry and combative, do you really? Perhaps you can wait another 10 or 15 minutes and approach John in a different way and think about how you might do that. Managers and unit leaders are integral in helping staff and giving them permission to alter those normal facility routines to better care for residents. Managers and team leaders can also be instrumental in helping families understand the care plan and why we're doing what we're doing. Behavior mapping assists us to determine what might be driving some of the behaviors we witness if simple observation does not clarify for us. Next slide. So let's start first of all with some tips for effective behavior mapping. Let's start with consistency. Just like implementing your care plan, if only one or two people do it, or one shift only does it, or it's sporadic, it is not going to be effective, and the data you get will be garbage. So everyone, and I mean everyone that touches the resident from all departments, should be behavior mapping if you've implemented that tool. The next thing is a clear description of behavior. Now, this is particularly important if you're using a document like the DOS, which relies on a one or two word descriptor. We often use vague and ambiguous terms. So I've had people say to me, oh, well, um, Mr. Mark is verbally aggressive and physically aggressive. I don't know what that means. I don't know what it is I'm looking for if you put that down on a behavior map. What is Mr. Mark doing? Is he punching? Is he hitting? Is he spitting? Is he swearing? Like what? So you need to actually tell me and write out specifically what the behaviors are. Mr. Mark punches and pinches. Mr. Mark screams, "Get out, I'll kill you," every time you approach him. That's very specific, right? And now everybody knows what we're looking for and can map effectively. Map only for 1 or 2 weeks at a time, please. Now, it's come to my attention that some teams believe that just because they're engaging in a process of reducing their inappropriate antipsychotic use, that everybody in that cohort they're working with has to be behavior mapped for the entire time. That is not true. You only behavior map on a resident when it's appropriate. So that might be when new behaviors have surfaced that you want to try and figure out why they're happening. It might be when you are implementing new person-centered strategies to manage responsive behaviors. It might be when you are deprescribing and you want to see how well the resident is doing as the drugs are being discontinued slowly. And you want to see how well your person-centered strategies that you've implemented simultaneously are working. Remember to analyze. If you don't analyze, it's not helpful. I was once consulted to a home in Winnipeg that was having a lot of difficulties with a resident. And when I arrived, they proudly handed me 3 big, thick binders full of DOSes. And when I look through it, it's week after week, month after month, year after year of DOSes. No one had ever analyzed these documents, so no one got any clues based on this behavior mapping. And so what ended up happening was people were just putting what the previous person put down because the staff determined that this was an exercise in futility. It was just a make work project. Nothing came of this behavior mapping. So please remember to go back and analyze and see if you can figure out what is happening and use those results to help guide the care planning. Next slide, please. So here you have a picture of a DOS. I love DOSes. If you're going to use a DOS, please use one that is unpopulated with behaviors so that you can put in your own specific behaviors. And when you are looking to behavior map, please don't list, 6 to 10 behaviors. Keep it short. The most risky or challenging 3 or 4 behaviors max. The nice thing about the DOS is it's quick, it's easy, it's very easy for all team members and all departments to use. It looks at a 24-hour period over a weekday, over a complete week. And so it's also very good to show trends very quickly and easily. Next slide, please. Here you have a more lengthy, detailed behavior map, which is great to use, I find, if the DOS yields no clues. This one comes from out east, and as you can see on the slide, you have the date and time of the behavior, the incident, the event, but also a spot for you to really describe in detail what happened, for you to describe what intervention you employed, and to discuss whether it was effective or not, and if the resident calmed down. Next slide, please. So here's a DOS again, and this one has been completed. So a team has done a week's worth of behavior mapping, and they decided to track slapping, which they deemed number 4, punching, number 5, screaming, number 6. So very specific behaviors. To analyze, they color coded after the week was finished. And so they made orange for screaming, slapping and punching, they put in blue. And you can see by doing this how easy it now is to see trends instead of just looking at numbers. You've got the colors helping you out. If you look at this DOS near the bottom, around the 5 to 7 a.m. time zone, you will see that all 3 behaviors seem to be happening pretty regularly every single day. And you might think, gee, I wonder what's happening here. If you think about it for a moment, it could be a couple of things. It could be the staff going in early to turn and change the resident, waking them and making them combative and upset and frightened, perhaps. It could be that, staff have to get X number of people up for the day shift, and this person is one of them, and this person is someone that doesn't like getting up at that time. So something to dig into. If you look throughout the rest of the DOS, throughout the rest of the day, from around 10-ish on to just before bedtime, around just after 6 p.m., you have screaming happening periodically, not all the time, but at certain times of the day. And if you look more closely, it tends to happen after meals. And so that might be another clue. You might think, I wonder if this person needed to use the restroom and we didn't do that. Or perhaps they had already soiled themselves and needed to be changed. There is an outlier on this DOS, and it's the blue on the last day of the week there, up in the early afternoon, and that's the punching and slapping. And I would bet money that if you went back and looked at the care plan, that this was bath day. Baths can be very traumatic, especially the way we tend to do it in long-term care. And residents are often combative during baths. It becomes traumatic for them and also for the staff. We'll talk more about baths in March's webinar for those participants that are enrolled in the AUA. Next slide, please. Here we have a completed behavior map of the more specific, lengthier type. If you look at the first line, February 9th, at 6 in the morning, the resident is screaming in bed. And so the individual tending to the resident got the resident up, brought them to the nursing station, and gave them something to eat and drink. And the screaming stopped, and in fact, they seemed calm and peaceful even 45 minutes later. If you go to the first February 11th entry at 7 a.m., screaming behavior, again, in the morning while in bed. This individual put the TV on in the room softly for the resident, and you can see it made no impact. The screaming continued even after 45 minutes. So here we have a clear clue that this resident needs to be up, whether it is their usual pattern of rising early or whether they're not comfortable in bed anymore. Consider that if this person has osteoarthritis like I do, you can't stay in bed for 10 to 12 hours. You need to get up. Next slide, please. So that leads us to huddles, another tool in your tool belt. Huddles are short, snappy, interdisciplinary meetings. They should be no more than 20 minutes in length, and you should be using only one huddle per resident. Some homes already do things like safety huddles, and they have all departments represented. Please don't combine. These should be separate for your work in deprescribing. You don't want more than 20 minutes in length. Your first one might be a little bit longer as you gain competence if you've never done a huddle before, but people don't have time to spend much more than that, so keep it short and snappy. It should be scheduled at first to make sure that everybody attends. It might take a little bit of effort to find a time that it works for everyone, but it's well worth the effort. It should be facilitated so that all team members get to participate. And I want to remind you that when you ask people like healthcare aides, um, uh, housekeeping staff, dietary staff, into a huddle to participate, they're not used to being asked for their opinions or their suggestions. And so they will stay quiet unless you call on them and ask them specific questions and encourage them to provide their suggestions. Remember, this shouldn't be this should be a safe space where everybody can offer suggestions and everybody can offer their opinion. That means that the facilitator needs to be skilled at drawing people out. Your huddle should be documented so that everybody knows what happened during the huddle afterwards and what the next steps are. And you should revisit your huddles. You shouldn't have just one. In the beginning, you might huddle a little more frequently as you start to employ strategies and as you start to deprescribe, but then your huddles may lengthen the space in between huddles may lengthen over time until you finally discontinue them on a resident. They should be used in conjunction with deprescribing. Next slide, please. Before the huddle, the facilitator has a little bit of homework to do. The facilitator should review the health record and look for things like diagnoses, current medications. Are there medications that perhaps are causing a medication cascade happening, and that's why we're seeing some of the behaviors we're seeing? Are there drug interactions that might be creating problems, etc.? Should look at the social history and assessment so that we get a better idea of who that resident was, what's important to them, what's meaningful to them. Should also look at the last week or two of documentation in your progress notes. Specifically, look at the documentation which describes the behavior and the events surrounding the behavior and what the team has done to mitigate or change the behavior. Look at any behavior mapping or DOSes that have been done, and hopefully they've been analyzed. Look at the resident care plan. Look at the consults, the most recent consults, to review any responses that have come back from the consults. Has this person, for example, had lots of UTIs and has been consulted, an ID has been consulted, infectious diseases, for example? Take a look at the lab values and see if anything is out of whack there that could be causing changes in mentation and, of course, perhaps even responsive behaviors because of that. All these documents should be brought with you to the huddle so that you can refer to them easily during your discussion. Next slide. So, some tips for effective huddles. For your first huddle, You need to give a quick explanation of what the purpose of this huddle is and how everyone is expected to participate. So if I was leading the huddle, I would say, thanks everybody for joining me. We're going to huddle on Bill today. We've had some issues with his responsive behaviors, and we also want to start looking at how we can deprescribe. I will be asking you for your suggestions and your help, and I would really appreciate it if you would participate. Shouldn't take more than 20 minutes. That's it. You need to begin by asking strategic questions to figure out what might be going on. So, for example, we're talking about Bill. Let's say the problem is that Bill doesn't like coming out of his room. He spends most of his time in his room, and every time anyone comes near him, he spits at them and he starts yelling and attacking. So you might ask, well, has anyone here experienced those behaviors when they go into Bill's room? And you could ask each team member individually. Perhaps you have someone like, I don't know, the housekeeper that says, well, actually, I've never experienced that. And I go into Bill's room routinely to clean. And he's never spit at me. He's never yelled at me. Well, then we might ask, well, why is it different for you? What do you do when you go into Bill's room? And the housekeeper might say something like, well, I knock on the door first and I wait for him to acknowledge. And then I come in and I say, hi, Bill, I'm Susie. I'm your housekeeper. And I say that every time because, Bill can't remember. He forgets, right? So I tell him who I am and why I'm there every day. And then I come ready with a joke because Bill has a great sense of humor and he loves jokes. So I tell him a little joke and we laugh and then we start to chat while I clean. I never have a problem with Bill. Well, then the next question is to the rest of the team, gee, do we do that? And if the answer is no, well, why not? How can we change things? So now you can start to make a plan. When you make a plan during your huddles for a person-centered strategy, please don't make a whole list of different strategies you're going to try because you'll never know which is working. Pick one or two things that you're going to work on now and maybe behavior map while you're doing that to see if it works. And then if it doesn't work, you might need to adjust, right? Or if it does work, great. What else do we need to do in terms of person-centered care to add on? Okay, next slide. After the huddle, it's really important that you document and communicate to the entire team. However you communicate, it's really important that it just doesn't live on paper or in the computer. Whether you put it information on the whiteboard in the nursing station, whether you use inter-office email, however, whether you use getting to know Jane Doe, John Doe, etc., you need to make sure that people know what the new plan is and that everyone implements it consistently. The team lead or manager or the facilitator needs to follow up with the team after the huddle within a day or two, just to make sure there are no problems. If you wait too long to intervene and things are not going well, the whole plan will fall apart. So you need to be supportive of your team and get in there right away and just double check. Have your next huddle scheduled and communicated to the team so that everybody can come together. And if you have elected to behavior map, which I hope during this time you have, people need to know that the behavior map is out now, where it's located, and for how long we're mapping. Next slide. So that leads us to a case study, just to put all these principles together. So Ruth is a 75-year-old woman admitted from hospital 4 months ago. She was hospitalized because of a severe UTI and prescribed risperidone 5 milligrams BID and 2.5 milligrams PRN for hallucinations because she was in active delirium. She was wandering, and that wandering has continued since admission. Her medical history includes advanced dementia, osteoarthritis, and congestive heart failure. Her medications include Tylenol for pain, Captopril daily, as well as Lasix and Slow-K for her CHF. Her needs include assistance with all her ADLs, dressing and bathing. She needs cueing to eat. She needs redirection for wandering, and she's incontinent. She can ambulate on her own without any aids. In fact, she probably motors pretty good. The problem is that in the last few weeks, wandering has really increased. She's now entering other residents' rooms, so she's become a Walmart shopper. And some are getting quite upset because she's in their rooms taking their things. She's becoming very difficult to redirect, and staff worry she's becoming physical. Some staff are advocating quite loudly for medication. Let's get more meds on her. Ruth's husband, Bob, is really quite upset because she was never like this at home, but he's really not happy with the prospect of more medication. So the team has come together to huddle and problem solve. So, what might be happening here with Ruth? Well, as a team, you might have some ideas, and some of the things that might be occurring with Ruth is she's suffered an awful lot of change in a short period of time. She got sick, she went to hospital, which was a strange environment. She suddenly got medicated, and then she got moved into a personal care home, which is also not her home. Um, Her dementia might be increasing. The risperidone might be preventing her from optimum mentation as well. We don't know. And it sounds like, there's other reasons for her wandering and picking things up. And so the first thing that we would do as a team is to review the history, check out to see who's noticed these behaviors and what are individuals doing. Is anyone successful with redirecting Ruth and why? Perhaps Ruth needs something to occupy her, but it has to be something that's meaningful for Ruth. I often see residents giving laundry to fold. Well, that's fine if that's something that they really like doing. But what if it's not? Here's an example of from my own experience. When I was director of care of a home, we had a resident who also displayed these behaviors. She was wandering and going into resident rooms, and she needed something to occupy herself. Her history revealed that she was the secretary for many, many years. And I decided we would try something rather unique. I went to my office and I found a whole bunch of old invoices that I was preparing to shred. I brought a stack of them to this lady. Her name was Irene. And I said, Irene, I wonder if you could do me a huge favor. I really need some help here. I don't have a secretary. Would you be willing to sort these in numerical order for me so that I could file them? Well, she sat happily for a few hours playing with these invoices. She didn't wander. She felt that she had purpose and it made her day. And so that's what we used to do with her when she wandered. So although Ruth is a case study and it would require more discussion with the team to figure out what the problem is, you can see how a huddle can really help you determine the best strategies to employ with your resident. I hope you've enjoyed this webinar. That's the end of our presentation today. Thank you so much.